In the MCQ also they can ask what are the negative prognostic factors. So for prognosis, when you say negative prognostic factors, they divided it into two. One is clinical. So this includes persistent jaundice, ascites, persistent jaundice, hemorrhage, and not responding to treatment. Then you have the biochemical. You have the biochemical prognostic factors. This includes low albumin, hyponatremia, high serum creatinine, and prothrombin time more than 6 seconds of expected value. Okay, this is also a MCQ discussion. So apart from that, to quickly go through, next is the important complications of cirrhosis. So this is the bread and butter of cirrhosis. So there are roughly 6 or 7. The important ones are portal hypertension, ascites and spontaneous bacterial peritonitis, hepatocellular carcinoma, and this thing, hepatorenal syndrome, hepatopulmonary syndrome. These two we don't need to know much, but just know hepatorenal syndrome a bit. We did it in surgery also under obstructive jaundice. And yeah, any infection, because you have loss of immunoglobulins due to the cirrhosis, and hemorrhage. So if you all should know each of this and roughly how to diagnose and treat, and like portal hypertension, ascites, the causes and stuff. Do you all want me to go through any of these, or shall we go to the history and examination? Any specific topic here you all like to go through, or shall we now go to the history and examination? Anyone? Did you do a bit on complications after the? Okay, I'll do after the history and management. Okay, after the history and management, I'll go through the management of the complications. Okay, little discussion, discuss. If anyone can use the mic and tell, it's easier for me, like, because I'm getting different. Okay, I'll go through the history and examination, and during the discussion, we'll talk about the complications. So, yeah, the history. So in any subject except maybe obstetrics and psychiatry, in the history of so we have the general information first, the usual name, age, occupation, location. If they are female, the last regular menstrual period. Then presenting complaint, they will say they came with abdominal swelling of 2 days duration, or they will come with saying altered sleep pattern of 1 day duration, something like that. Then in the history of presenting complaint, this is the main part. So in any subject, an easy way to go through the history of presenting complaint is 3 things. So you don't forget. First is symptomology. Then it's etiology and DD. Finally, it's complications. Okay. So for symptomology, when they say they came with edema, so edema, usually any symptom, there are specific questions we have to ask. The famous one is for pain, we go through Socrates, like site, onset, character, radiation, blah, blah, blah. Then for hematuria, we say throughout the stream, start of the stream, end of the stream, pain, fever, chills, blah, blah, blah. So similarly, for edema, we have, we have onset, progression, timing, and any associations. Okay. So for onset, you ask, how did it begin? And then you can ask the site of onset. This gives a big hint what type of edema it is. Then they will say abdomen, or they can say face, or they can say legs. Okay. Then you ask them the progression. Did it go from legs to abdomen, etc. And how long it took. Finally, the timing. So the timing also gives us a good indicator of the etiology. So if it's morning, it supports renal. If it's evening, it supports heart. And yeah, that is for the symptomology. Then that is just to get a basic idea of about the edema. Then you go into the etiology. So what we have to first think, what are the differential diagnoses that can cause generalized or abdominal edema? So it's always the failures, the heart failure, the liver failure, and the renal failure or nephrotic. Rarely, for extra points, you can say hypothyroid, but I would suggest even if you don't say, it's fine. And if they are only ascites, it can be other stuff also, like other diseases. We'll discuss SARG later, such as TB peritonitis and malignancy. Now, this is important because one of my friends, he got a case where in his long case, it was a patient with only ascites, a female old patient, and he got it with normal ulcer, and they had the usual cirrhosis discussion. They went into SARG, and then he said he has a what do you call that? A less than 11. And then he said, what are the causes? Then when you go into malignancy, sir asked, what are the tumor markers? And then he said CA125, and it turned out to be an ovarian cancer case in a medical long case. So I think it's better to remember this. If there's only ascites, you ask about these two. So what can we ask about in the heart? The usual heart stuff we ask in shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, exertional SOB. This is for congestive cardiac failure. Okay. Then we have for liver. What are the stuff we ask for the liver? So for liver, we can ask about, you can ask about obviously jaundice, drowsiness, hematemesis, and melena. Bleeding goes both ways, up and down, hematemesis and melena. Sorry, it got a little this thing. Then for, if you have any questions, you can ask me or you can send a chat thing. Then for renal, what are the questions you would ask? You would ask about frothy urine. You would ask about pruritus. And it's very good to ask if they have a history of diabetes or SLE. That is mainly for nephrotic syndrome, because adult nephrotic syndrome is also quite common. So hypothyroidism I'll skip. And then for TB peritonitis, the usual TB questions: loss of weight, loss of appetite, history of TB, contact history of TB, chronic cough with hemoptysis. Yeah, because they can get peritonitis as a result of TB which has spread from the lungs. And then for malignancy, there is nothing much to ask, but just keep it as a differential diagnosis, because it's the same loss of appetite, loss of weight from TB. Now, after you come here, you will realize, okay, my diagnosis is probably one of these. So for what do you call that? Discussion's sake, let's assume it's liver. So time to ask questions regarding those. Now you assume it's liver, no? So now we have to go into etiology, okay? Before you jump into complications, you have to go into etiology. So those etiologies I discussed with you all: non-alcoholic fatty liver disease, alcohol. So you ask them alcohol. So in the alcohol history, there are several important things. One is type of alcohol. Then you have amount of alcohol per week. If you can, you describe it in units. Unfortunately, I cannot remember the units. It's quite difficult also, but if you can, it will be a very good plus point. And finally, you have to know if they are dependent on alcohol. This is very important because they ask in the Viva, is he alcohol dependent or not, according to ICD-10 criteria. You don't have to ask all 6 questions. You can quickly ask, are you withdrawal tolerant, and do you always want to drink alcohol, and do you feel guilty? Those are enough. So then you can say if they are dependent. These are the things you ask in the alcohol history. It's better if you ask if he's an alcohol person, better if you describe it here rather than the social history. Then alcohol. Then for non-alcoholic fatty liver disease, just ask if they have diabetes and obesity. You can just ask have you checked your weight? Obviously, if they look obese, they're obese. Then hypertension, and if they have cholesterol. And for how long? Now, if any of these is positive, I would suggest explain it in past medical history. So if diabetes is positive, you do it in the past medical history, because having diabetes is important, but the content is not that important here. So then the other etiological factors you should brush through. One is hepatitis B and C. Hepatitis B and hepatitis C. So these you ask if they have any blood transfusion, risky sex behavior, and IV drug use. Finally, just for completion's sake, you can ask about autoimmune hepatitis. Just ask if any other diseases they have. If they say yes, ask if it's what is the disease. Then with our knowledge, we know if it's autoimmune or not. And if the patient is a young patient, ask about Wilson's disease. So in Wilson's disease, you have deposition of copper. So copper deposits in the liver and you get cirrhosis. Copper deposits in the eye and you get casophagia rings. Copper deposits in the nerves and you get tremors. Copper deposits in the cerebellum and you get ataxia. So you can ask these 3. Don't need to ask casophagia rings, that comes in examination. You can ask tremors and ataxia. And Wilson's disease is autosomal recessive. So you can ask if parents are related to each other, consanguous or not. So that covers the etiology and DDs. Finally, we have the complications. So I'll write it here. So the complications are what we spoke about. Have they had any episodes of hematemesis? What happened? When? Where? And how it was managed? For hepatorenal, ask if they have reduced urine output. That's about it. Then for ascites, they came with ascites, so no need to ask about that. Hepatopulmonary, actually, we don't need at all. Just know it exists. So in MCQ, if they ask, you can say yes. What else were there? Yeah. If they have SBP, if they have abdominal pain, fever, and yeah, mainly abdominal pain and fever. And SBP. Yeah, that's about it. And any regular infections. And yeah, that's it. Yeah. And alcohol, whether they have any episodes of binge drinking or yeah, binge drinking. And I forgot the most important one, sorry, hepatic encephalopathy. You can ask questions according to West Haven classification. If you all don't know this, I'll discuss it briefly in the discussion. So this is the history. Okay, I know it looks a lot, but it's all very, you can work it out. So don't worry if you don't get it today. You study the theory, and then you just remember these 3 points for any history: symptoms, etiology, complications. So any case, I guarantee you this will work out. This is what I use usually. And because it's difficult to memorize the questions, so you can go through this. So quickly to go through it again: edema, onset, duration, progression, timing, association. So the onset, if it's in the face, you can suspect renal. If the onset is in the legs, you can suspect heart. If the onset is in the abdomen, you can suspect liver. Now the reasons for this is, in the heart, the most dependent part is the legs, where the blood has to come from. So in the heart problems, it is the legs. Whereas in the liver, it is the abdomen because of 2 reasons. One is hypoalbuminemia affects everything now, but you get portal hypertension. So as a result of portal hypertension, you get increase, if you remember Starling forces, that H thingy. So you get increased portal hypertension, you get increased hydrostatic pressure. So in the abdomen only it begins. Regarding renal and the face, I don't know why. I have asked also. No one has told me why. So just remember renal and face, because obviously other 2 you know. Then the timing. The heart is in the evening because as the day progresses, the workload of the work we do and all increases, and there is stasis of blood in the evening. And when you wake up, if there is swelling in the face and all, it's renal. So in the etiology, heart, we ask the usual heart failure questions. Liver, you can ask about jaundice, and you can ask a little bit of the complications there. Renal, you ask fatty urine, pruritus, and DMO SLE. Now regarding pruritus, it occurs in both liver and renal. In liver, it occurs due to unconjugated bilirubin, whereas in renal, it occurs due to urea. So that is the pathology. If they ask, you can tell. In the liver, it is due to unconjugated bilirubin. In the renal, it is due to urea. Then forget hypothyroidism. Then if it's only abdominal ascites, you can ask about TB, peritonitis, and keep malignancy in your mind. Use an example I said, that ovarian cancer lady. Then assuming it is liver, into alcohol, type, amount, dependence according to ICD-10, the psychiatry thing we learned. Then non-alcoholic fatty liver disease, you ask metabolic syndrome, that is diabetes, obesity, hypertension, cholesterol. If it is positive, explain it in the past medical history. Then hepatitis B and C, blood transfusion, risky sex, IV drug. Autoimmune, if they have any other autoimmune diseases. For example, diabetes type 1. They will tell the video had una podi kale and insulin gahana, stuff like that. Or hypothyroidism. Or SLE, something like that. Anything. Finally, if they are young, around 30s, let's say, remember Wilson's disease. Especially if you get like a neurologist or someone in your panel, they will definitely ask about Wilson's disease. There are other conditions I didn't talk about, like hemochromatosis and all, but we'll do that in a discussion more than here. It's not needed here. Then complications. Hematemesis, you should ask what happened, where it happened, how it was managed. So management, you all know, right? So you give, if you all don't know, drop a message. We can do it if we have time today, or you can do it separately with another topic. Then spontaneous bacterial peritonitis, abdominal pain, fever, infection. Remember, this can be asymptomatic also. Then alcohol and hepatic encephalopathy, according to West Haven classification. Yeah. Okay. Shall I move on to the examination? Any questions? You can DM me. Yeah, I will do the management in the discussion after the examination. Which management do you want me to do? Like, anything specifically? Okay, shall I go on to examination then? I'll clear this. It's all right, right? Okay. So now I will draw a person. Use my drawing. Okay, this is a person. So examination. We have to do a quick examination. So the person is lying down. I'll go from head to toe approach. You start at the forehead. In the forehead, what do you think we look at, anyone? You check if they want to touch because of spontaneous bacterial peritonitis. After forehead, we have to go to the eyes. So in the eyes, what we look at is if they are jaundiced, obvious one. If they have case-of-leisure rings, we may be able to see. And if they have any xantholesmas above the eye. So xantholesma is, you all have seen in the medial side of the eye, below the eyebrow. Okay, xantholesma. The reason is jaundice is a complication. Case-of-leisure ring is a etiological thing for Wilson, and xantholesma is etiological thing for non-alcoholic fatty liver disease. Then we look at the cheeks. We look at the cheeks for parotid enlargement, bilateral parotid enlargement for alcoholism. It is not an indicator of cirrhosis, it is an indicator of alcoholism. Okay. Then we go to the chest. Now I drew these nipples for a reason, not because I like them. So here above the nipples, you look at spider nevi. Now, Dumita madam always says he will ask why you get spider nevi and stuff like that, especially in the short case. So spider nevi are arterioles surrounded by draining veins. So it's like like I'm sure you all have seen, it's like this with a central thing like this. And when you press the middle, it will disappear. So this occurs because the arterioles expand. And why do the arterioles expand? Because the metabolic function of the liver is affected. So estrogen is not broken down. So it increases and causes vasodilatation. Okay. So that is that. So in fair people, especially white people or even fair girls and boys, it may be normal to have 1 or 2 spider nevi. So usually we say look for at least 5 spider nevi, at least. But if you have 4 also, like, you can take it. It's a relative thing. So it is similar to cafe au lait spots in neurofibromatosis. You look for around 5, right? So similar to that, it is spider nevi. Then we look at the nipples. we look for gynecomastia. This is also due to estrogen. Now here, important thing is you have to differentiate from pseudogynecomastia. Does anyone know how do you differentiate gynecomastia from pseudogynecomastia in the examination? You all can unmute. It's fine if you all need to.
Tender.
Yeah. One is it can be tender in gynecomastia. Second is pseudogynecomastia කියන්නේ there is fat. So if you touch around the nipples, it's just fat. Whereas in gynecomastia, it's breast tissue. There is real breast tissue. So when you touch around the nipple, you can feel like this breast tissue like thing. So there's two things. One is tender and one is the breast tissue. So if they ask you, how did you say it's gynecomastia or not? And obviously in pseudo, the person will be obese. Okay. Then we move on to the, I'll draw on the left side, the hands. So in the hands, what do we do? Apart from the usual pulse, blah, blah, blah stuff, I'm saying the specific stuff, you check for asterixis, that is flapping tremors. Flapping tremors is a sign of hepatic encephalopathy. So if they have flaps, they are probably in hepatic encephalopathy. You look for palmar erythema. This also occurs due to estrogen. So vasodilatation, more blood goes into the hand. It is red in color. That's why pregnant people have red hands because of estrogen increase. Then you check for Dupuytren's contracture. So Dupuytren's contracture, you feel the medial side of the palm and it's hard like fibrosis. This is a sign of alcoholism, not cirrhosis. So there are two signs of alcoholism, parotid bilateral and Dupuytren's contraction. So if they have both of it with cirrhosis, you can say probably due to alcohol. And is there anything else in the hand? If there is, I'll come back to it. I can't remember anything else. Then you look, before we go to the abdomen, we'll go around it. You look at the thigh. So when a person is very scratchy due to kidney disease or liver disease, they scratch two places. Scratch. One is the thighs because it is easily accessible. Other is the upper arm. So when you're doing examination, just look, are there scratch marks and stuff like that. Yeah, in the hand, I forgot. The other one is leukonychia. White nails. If there are half and half nails, you suspect CKD. If there are white nails, you suspect liver disease. Okay. So feet, you look for. Sorry, what happened to this? Yeah, feet, you look for edema, ankle edema and stuff. So now we come to the main worrying place, the abdomen. You do the regular abdominal examination, inspection, palpation, percussion, auscultation. So in inspection, you, sorry, keyboard. Inspection, you can say abdomen is distended equally. And then you can look for any caput medusae. It's like spider nevi, but in the abdomen. And apart from that, you can see if there are any obvious things like if there is skin pigmentation. So if the patient is very dark or if the skin is pigmented, you have to think of hemochromatosis. I forgot to say that, I'm sorry. Hemochromatosis if dark or pigmented. Anywhere in the body, if it's dark or pigmented, hemochromatosis. Then you go to the palpation. So liver is usually not palpable in cirrhosis because it shrinks. But what is palpable is the spleen. because of portal hypertension. Okay. Then you go on to the famous fluid stuff. So you go to percussion. In percussion, you check the fluid things. So you go with flank dullness, horseshoe dullness, shifting dullness, and fluid thrills. These things will be, I think, better. No point saying it online. When you all do the short cases with someone, they will, if the good patient, you can elicit these stuff. And yeah. And if you can get permission from the patient, like if he's obviously cirrhosis, you can go to this area. You don't have to do it, but if you do it, it's like a big plus point. Madam and sir will be impressed. You can check for testicular atrophy. So they can ask you, how can you confirm it is atrophy? You can say ultrasound scan. Okay, so this is the examination stuff. So you start from the, just quickly go through it. Start from the forehead, warm to touch. Eyes are jaundice, Kayser-Fleischer ring, xanthosema. Parotid bilateral enlargement is alcoholism. Anywhere, if they are very hyperpigmented, you know when you see it. Then they are hemochromatosis. And spider nevi, if they are above, usually spider nevi is above the nipple level because it drains from the superior vena cava, spider nevi. So it's above the nipple level. So arterioles surrounded by draining veins due to estrogen. Then gynecomastia. Then in the hands, flapping tremors, palm erythema, deputrans contraction, leukonychia. Then in the legs, scratch marks and ankle edema. Then you go to the abdomen. You can check it with E. coli distended, caput medusae. Anything you see, you tell. Like if you see any liver biopsy marks above the right hypochondrium, you can say that. Yeah, like that. And I'm sorry, I forgot to tell you one important investigation thing is peritoneal tap marks. So for this, you look at the left side of abdomen, left lower side of abdomen on lateral aspect. Pleural tap marks. So this is a good thing if you say. So it means that you have looked for complications of cirrhosis like ascites. Then for palpation, the fluid stuff, flank dullness, percussion, flank dullness, horseshoe dullness, shifting dullness, fluid thrills. And there's one more thing. Yeah, that's about it. You can check for constipation and all within the left lower flank and all, but I don't know if they will like it because constipation can lead to hepatic encephalopathy and all, but that's a stretch. So this is examination. Examination. Yes, that's about it. Okay. Any questions or anything? If you have missed or made a mistake, please let me know. Shall we move on to the discussion? Okay. So is anyone want to do a discussion with me? Does anyone want to do a discussion? Don't worry, we are all friends here. There is no judging or there is nothing wrong. So I'm 100% sure all of you all will pass. I'm 100% sure. So anyone would like to do a discussion? Anyone? At least little questions. I won't ask all. Just basic stuff. Okay, that's fine. Okay. Okay. So then they will ask you, what do you think the diagnosis is, or something like that, based off the history and examination. So when they ask you diagnosis in SCQ or MCQ, there are three things. Like they always ask in SCQ, what is the diagnosis? What is the diagnosis? You say the diagnosis. Example, cirrhosis, decompensated cirrhosis. Then they ask, that's the first part. Then you have to say the etiology. Due to alcoholic liver disease. Finally, you say the complication. Now, why do we say decompensated? There's obviously complication. Complicated by ascites and jaundice. So if they ask what is the diagnosis, madam or sir, my complete diagnosis or my tentative diagnosis is decompensated cirrhosis, probably due to alcoholic liver disease, complicated by ascites and jaundice. So to get a full mark for diagnosis in SCQ also, you should say these three. Okay. Then they will say, what are the investigations you would like to do? So for the investigations, you can say, I would like to do some investigations. I would like to do some blood investigations. These include, you start with the basics. Basics are basics. Full blood count. So what do you look in the full blood count? Anyone? You can message or you can talk, which I prefer. Full blood count, what do you look? Think of the diagnosis and think of the etiology and think of the complication when you're answering the investigation. Anyone?
Platelets and they can have thrombocytopenia.
Exactly.
Yeah. So thrombocyte.
Or infections if it was etiology.
Yeah.
Right?
Exactly.
Thrombocytopenia.
Yeah, so this is it. In the full blood count, one thing you look for is thrombocytopenia. Because of portal hypertension, spleen enlarges and it can work over time and you can get hypersplenism. Initially, it is thrombocytopenia. Later, it is pancytopenia. Second thing you look at is white blood cell count. If they have spontaneous bacterial peritonitis, white blood cell can increase. Or if their hepatic encephalopathy is caused by an infection, white blood cell can increase. So that is one investigation. The next investigation is the important one. Liver function test and liver biochemistry. So liver function test, as the name implies, you check the function of the liver. So if you all remember, I said serum albumin checks the long-term function. Whereas PTINR checks the short or recent function, short-term function. That's why if you all remember, in paracetamol poisoning, we check the PTINR. When we ask for PCM levels, blah, blah, we ask for PTINR because it shows if there is acute liver damage. And the other component of liver function test is serum bilirubin, total serum bilirubin. That is for jaundice and stuff. So liver biochemistry are the enzymes. You have AST, ALT, ALP, and gamma GT. I'll quickly go through each investigation. So I have already gone through liver function tests. So AST and ALT. Since ALT has an L, it is liver specific. It's easy to remember. Whereas AST, not specific, it is more specific to liver. More specific to liver. Whereas AST, it is also there in heart. So it is used, it used to be used as a cardiac marker, as a, what do you call that? Electroporin, cardiac MI marker, because it increases in MI and stuff. So ALP. ALP occurs, ALP is produced in the canaliculi and stuff. So it increases in obstructive causes. And finally, gamma GT is a marker of alcoholic. And also in non-alcoholic liver disease increases. Okay. So these are the investigations: AST, ALT, ALP, and gamma GT. So some important facts in regarding to these investigations are, in cirrhosis, albumin to globulin ratio reverses because albumin drops. These are like MCQ things. If you can remember, it's good. If you can't, it's fine. Hello? Yeah. And in alcoholic cirrhosis, AST is more than ALT. Usually AST and ALT are less than 40, if I recall, right? In stuff like hepatitis and all, it massively increases to 1,000, 1,500 and all. Yeah. So that is liver function test. So one investigation is full blood count. Other one is, one investigation is full blood count. Other one is liver function test. So another investigation is, yeah. Remember I said prognosis, there are some stuff we can look for. So one is serum creatinine. If it is more than 130 micromoles, or 13 or anything, 1.3 or whatever unit you use, if it is more, it is a negative prognosis and may indicate hepatorenal. Other one is serum electrolytes. Hyponatremia is negative prognosis. So these are some investigations. Okay. So apart from this, you can do CRP, and depending, like if you came with a, if he says abdominal pain and all, you can do CRP, and yeah. And if they have ascites, and if the diagnosis is not certain, you can go ahead with a peritoneal tap as an investigation. Not parasynthesis, tap. You take 10 to 20 ml of fluid, and there are multiple investigations you do. These include ascites albumin, gram stain and culture, gram stain and culture, cytology, amylase, even TB PCR. So the reason for each is, ascites albumin we do for SAG. Gram stain and culture we do for spontaneous bacterial peritonitis. Cytology we do also for SAG and any malignant cells. Amylase we do for pancreatitis. TB PCR we do for TB peritonitis. Okay. So these are the sorry, this is not a blood investigation. This is a different one. Finally, we have the radiological investigation, which is the ultrasound scan. So what do we look for ultrasound scan? We look for diagnosis and we look for complications. Sorry. So in the diagnosis, we look for granular contracted liver with nodules. We look for increased echogenicity with fat due to fat and fibrosis. Okay. What are the complications we look for? You can look for splenomegaly. You can confirm ascites. And you can look for suspicious hepatocellular carcinoma. Okay. Now these are the investigations you do, mainly for diagnosis and complications. Okay, guys. So now for etiology. If it's alcohol, you can get an idea by gamma GT and examination. Okay. For NAFLD, you can do fasting blood sugar or HbA1c. You can check his pressure. You can calculate the BMI. All this is for non-alcoholic fatty liver disease. For hepatitis, for viral etiology, you can do the hepatitis B serum stuff, the antibodies and antigens. That's a separate topic under John. Hello, can you hear me?
Yes. You can.
Okay, sorry, Girapa Vairagada. Can you make me host? Am I host? Yeah, I'm host. Okay. Where did I stop? Hemochromatosis. So, hemochromatosis, we do iron studies. Now, do you all remember in anemia also we do iron studies? So, the same stuff, but the results are opposite. So, here serum iron is high. Serum ferritin is high. Total iron binding capacity is low. Okay. So that is for hemochromatosis. So investigations, we did investigations for each thing now. Sorry, my flow got upset. Yeah. Finally, we have the, for final etiologies, this is quite difficult to memorize, is autoimmune. Here there are multiple different antibodies. If you can remember, it's very good. If not, it's fine because it's quite hard to remember. So smooth muscle antibody. I'm also referring and writing this because I don't remember at all. It's for autoimmune hepatitis. Antimitochondrial antibody is for primary biliary cholangitis. Cirrhosis, sorry. And yeah, like that there are different types. And then there are advanced investigations, such as MRI liver biopsy. Usually you don't need to say this stuff. If you all have come this far, means you all have definitely passed. So I won't go that much into detail into those stuff. So that is the investigations you would do. So now we'll move on to management. So if a patient comes with ascites, how do you manage? Anyone wants to quickly rush through this? Anyone who knows? So I can see like what I should add to it. Anyone? You all can type very briefly if you all want. It's fine. I'll quickly go through it. So if a patient comes with ascites, you have to look at first main thing you have to look at is he in encephalopathy? If hepatic encephalopathy equals yes, treat only hepatic encephalopathy. Only treat ascites if difficult to breathe or or tense abdomen. Here do limited paracentesis of 500 ml. So this is the thing. If they come with ascites and they are drowsy, inverted sleep, coma, anything like that, you don't treat the ascites, you treat the hepatic encephalopathy. However, if they can't breathe, obviously you have to relieve the ascites. So there you do a limited paracentesis of 500 ml, very little. Okay. So that's that. Then we have, if they are not in hepatic encephalopathy, so if they are not in hepatic encephalopathy, if hepatic encephalopathy equals no, we have to treat the ascites. So you have to admit them to, you don't need to admit them to acute side. So maybe subacute or chronic. And then you have to do the non-pharmacological plus pharmacological. There are two parts for any disease, basically. So non-pharmacological. What do you do for non-pharmacological? you have to give salt restriction, no added salts, and less than 2 grams, they say. But ideally, no salt should be given to the patient, if I recall right. Yeah, wait, let me check. Yeah. So the important thing is their calories and their proteins should be normal, because you do not want them to go into hepatic encephalopathy. If you give them too much protein, they can go into hepatic encephalopathy. If you give too little protein, they can go into hepatic encephalopathy. Sorry, too little protein, they can go into what do you call it, catabolism and stuff. So basically, calories normal, protein normal, not protein restriction, protein normal. Okay. Now, does anyone know how do you say less than 2 grams of salt per day? How do you tell the patient? Like, how do you practically tell the patient?
Like you give it to a spoon, I think half of that, you divide it into something like that. I can't remember.
Yeah,
Yeah,
similar.
similar. Yeah.
So you take a
You take a
teaspoon and half of that. And from that, you take another half, because this is 2 grams. It's a tiny amount. And this amount you give for the full day. There another. You take you take a teaspoon, not table, half the teaspoon. From that, another half, and you give that for the full day. So for the morning, so Sri Lanka is no Udeta bat, Davalta bat, Rata bat, Jameta bat. So all that only from this quarter. Okay. So that is the non-pharmacological management. Yeah. I'm sorry, after admission, there are some charts we have to put. So the charts, you have to put a temperature chart. Why? For spontaneous bacterial peritonitis. You have to put a daily weight chart, because you have to measure the weight daily, because I'll tell about it later. Then you need a input-output chart. And if possible, abdominal girth. And it's better if you put a blood pressure chart also. Okay, these are the charts. I'm sorry, I forgot to say that. Then we go into pharmacological management. So this is the bit of a long thing. The aim is to reduce 700 to 1 kilo per day. That is the aim. And we do this by diuretic therapy. So the main drug is spironolactone. We give 100, we need to know the doses here per day. The other drug is furosemide. We give 40 milligrams per day. Sorry, 40, not 10. These are the starting doses. For these to work, may take 2 to 3 days. It may not work on day 1 itself, the weight loss. It may take 2 to 3 days. So the max dose is 4 times the minimum dose. So spironolactone is 400, furosemide is 160. You have to memorize this stuff. It's very easy, right? Spironolactone 100, furosemide 40. Might take 2 to 3 days. Max dose is 4 times the value. So 400 and 160 per day. Huh? Okay. So now there are some problems. Now, giving diuretics like this, obviously there are side effects. Spironolactone can give you hyperkalemia, furosemide can give you hypokalemia, these can cause hyponatremia. So for that, you do some investigation. Every other day, you have to do serum electrolytes. Why? Because if potassium goes up, like I can't remember the value, but hyperkalemia, you have to stop. If sodium is less than 128, you have to stop. This is why we do serum electrolytes every other day. Another investigation we do is serum creatinine. Because if, what do you call that? If it increases, we should stop. Okay. So apart from this, yeah, and you have to always be, this is the important thing, always be vigilant of hepatic encephalopathy. So I will talk about hepatic encephalopathy next. After that, I think we are done. Yeah, always be vigilant of hepatic encephalopathy. So aim is 1 kilogram per day. Any questions up to now? Anything which is not clear? So just to quickly go through, patient comes with full bladder ascites. You check, is he in encephalopathy? Is he sleep normal? Does he have constructional apraxia? Is he coma? Is he any drowsy? If it is yes, you should treat hepatic encephalopathy. However, if he can't breathe or the abdomen is massive, you can do a limited paracentesis. Okay. If it's not hepatic encephalopathy, you have to treat the patient. So you admit him. No need to admit to acute. It's not an acute problem. Then you start him, on some charts, temperature chart for spontaneous bacterial peritonitis, daily weight chart, because our aim is 1 kilogram per day. So you have to make sure the weight goes down. Intake output chart, because this is a fluid related problem. Abdominal girth, because to see if the ascites is reducing, and blood pressure, because there's loss of fluid now, you can go into hypovolemia. You can go into hypotension. So you do a blood pressure, especially postural blood pressure, because that is the first thing to drop. Then management includes non-pharmacological and pharmacological. Non-pharmacological, you have to reduce the salt to less than 2 grams per day. So this is the teaspoon method. If this teaspoon thing is wrong, please let me know. This is what I was taught by an intern here. So if it is wrong, let me know. Calories and protein normal. So calories you calculate according to the Harris-Benedict formula. If you can remember, it's good. Protein, the normal protein, 1 gram or something. Then pharmacological management. Aim is 1 kilogram per day by diuretic therapy. Main drug is spironolactone. So what are the complications of spironolactone? Hyperkalemia, because it is potassium sparing. Gynecomastia. So they might have pain. They anyway can have gynecomastia, and they can have painful breasts. So apart from that, hyponatremia and all. Then fusimide. Side effects of fusimide is ototoxicity, hyponatremia, hypokalemia. So to monitor all this only, we do serum electrolytes on day 1, then day 3, then day 5, then day 7, blah, blah, blah. If potassium is hypokalemia, stop. If sodium is hyponatremia, stop and do water restriction. Then you have serum creatinine. If it increases, we should stop. Max dose is 400 to 160. Okay. Now I'll go into little extra. Like if you all don't remember this, it's okay. If you do, you'll get a good mark. Refractory ascites or resistant. This means at max dose of diuretics, no working, no reduction of ascites. Okay. ඒ කියන්නේ 400ක් දීලා 160ක් දීලා වැඩක් නැහැ, වෙනසක් නැහැ. So what do you do then? Here only we do the thing we see in the ward. Large volume therapeutic paracentesis. Large volume therapeutic paracentesis. You can remove, I think, a large amount, but after 5 liters of removal, for every liter, you give 8 grams of salt-free albumin. This is the thing. This is the important thing. In resistant ascites, we do large volume therapeutic parasynthesis. After 5 liters, for every liter, you give 8 grams of salt-free albumin. හරිද? එච්චරයි දැනගන්න ඕනේ. So if this doesn't work, there is a thing called TIPS. If that doesn't work, you have to go to liver transplant. Yeah, ඒව ඕනේ. Okay, shall I move on? Is there any other question here in ascites? So as I typed here, next is spontaneous bacterial peritonitis. If they have fever and abdominal pain, you directly start the treatment. You take full blood count, CRP, you take a blood culture, and then you start the patient on treatment. However, they can have even asymptomatic. So in that case, during a pleural tap, we do cytology. If neutrophil is more than 250, we start antibiotic. So which antibiotic do we start? Since it's abdominal, intestine related, it is E. coli. So E. coli, you give third gen cephalosporin. Okay, 1 second. Okay, that's it. Third gen cephalosporin. Harine. Now, one important thing they can ask you is, in nephrotic syndrome, if they get spontaneous bacterial peritonitis, what is the antibiotic of choice? What do you all think it is? Because adults also get nephrotic in diabetes and stuff. What do you all think the antibiotic choice is and why? Okay, it's fine, I'll tell. The antibiotic of choice is penicillin, because in nephrotic, you lose complements. So these capsulated organisms only cause problems, such as pneumococcus. So for pneumococcus it's a streptococcus. So streptococcus, you give penicillin. So in nephrotic patient connect now, you give penicillin. Make you give third generation cephalosporin like cefotaxime or ceftriaxone. RNA. So this is okay. This is done. Next is hepatic encephalopathy. So in this, there's a thing called West Haven classification. There are four what do you call that, stages. Stage 1, they get constructional apraxia and inverted sleep. Stage 2, they get flaps, drowsy and stuff. Stage 3, they get stage 4, they get coma. Stage 3, I cannot remember. They get something. I'll refer it and let you all know. What's important is stage 1 and 2 anyway. So the first thing they get is constructional apraxia. So in the history, when you take the history on your paper like this, just to show the examiner that you excluded hepatic encephalopathy, you can tell the patient to draw a 5-pointed star or a clock. Clock takes time now, so do the 5-pointed star. If they can't, it means they have constructional apraxia. That is the earliest and first sign of hepatic encephalopathy, not flaps. Flaps usually occur in stage 2. It can occur in stage 1. Okay. Next is inverted sleep. Udayata budhi, rata, they are up like us. So if they have inverted sleep, also it suggests hepatic encephalopathy. Then you have flaps. There is asterixis, hepatic flaps. And finally, you have coma. So So yeah, so then yes, third is confusion. Sorry, that's what I wanted. Third is confusion. So how do you treat hepatic encephalopathy? So you don't do, even though there are specific investigations, you don't do those. It is clinical diagnosis. And it is actually, it is sort of an emergency because they can die. So to stop hepatic encephalopathy, there are many parts. One is treat the cause. So what are the precipitants of hepatic encephalopathy? It can be caused by constipation, infection, drugs like these sleeping drugs, or benzodiazepines, stuff like that, and even hyponatremia and stuff due to over drinking water, etc. So one aspect is we have to treat the cause. So stop the offending drug and blah blah. Then the main mode of management is two drugs, two classes of drugs. One is lactulose syrup. Here you give 10 to 20 ml, and you aim for at least 3 soft stools per day. Okay. So the problem with hepatic encephalopathy is bacteria act on the gut and they produce ammonia. Ammonia goes to the brain and causes conversion of glutamate to glutamine. Glutamine draws in water and causes edema. So what should we do? We should attack this ammonia. So what lactulose does is it what do you call alters the colon pH and limits the ammonia production, and it also makes the constipation, stops the constipation. So it stops constipation and affects pH, so less ammonia production. We don't give enemas because if you give enemas, if they bleed, they will keep bleeding because PTINR is affected in cirrhosis. So you don't want to cause them to bleed. Anyway, they bleed now. So yeah, that's why we don't give enema. The second class of drugs is antibiotics. You have the R's. Sorry, you have rifaximin and metronidazole. The doses are a bit different in UHKDU. So I suggest you go and ask the intern IRs in the ward, what is the rifaximin dose? Metronidazole is 400 milligrams TDS. Okay. Then since they are acutely ill and all those stuff, you treat them ideally in the, I mean, if you have space, you treat them in the acute side. You give them a bed, you prop up the head end and head in midline. This is because you want to allow the blood to drain and not to kink any veins. Okay, you prop up the head and you keep the head in the midline. So then again, you do the charts, input, output, temperature, and even BP and all, it's good to keep. So since they can be confused or coma, you may need NG tube feeding and bladder and bowel care. That is bedpan and catheter and stuff like that. That depends patient to patient. I think that's about it. Hepatic encephalopathy. Did I miss anything? Any questions so far? I think we are done. I will talk a little bit about child puke because it comes for the MCQ. Child puke has 5 parts. First 3 are liver function tests. So it's easy to remember. What are the liver function tests? Albumin, PTINR, serum, bilirubin, total bilirubin. The other 2 are ascites and hepatic encephalopathy. This is a prognostic indicator of liver disease and see suitability for liver transplant. That's about it. Just remember this value. Child pug has 5 parts. First 3 are liver function tests: albumin, creatinine, total bilirubin, ascites, and hepatic encephalopathy. So if they ask jaundice is a component of child pug, false. So yeah. Any questions? I think we are done. The main parts are HRI, I think. Regarding the abdominal examination, I think better do in the short case itself. Do you all want anything else to be done? Any other thing? Yeah, so we did complications wise, we did ascites and hepatic encephalopathy. Oh yeah, SAG, I'm sorry. Yeah. Give me a second. Anything else? Okay, hematemesis. Okay, I'll do SAG since it's very short. And then hematemesis, I'll do it. I'll do it. Yeah, we have time. Okay. SAG. So what is SAG? Serum albumin to ascites albumin gradient. This is what SAG stands for. The purpose of SAG is to identify give a hint about the cause of ascites. So we need 2 things for SAG. We need serum albumin and ascites albumin. And we calculate SAG by subtracting serum albumin from ascites albumin. That's basically the equation. It's pretty simple. So depending on that, there are 2 things you can get. One is SAG, low SAG, that is less than 11 grams per liter. Okay. So the causes are intra-abdominal, but not liver, liver associated. For example, TB peritonitis, malignancy. These 2 are the main, apart from this nephrotic and pancreatitis. If you can remember, good. If you can't, it's fine. So if the SAG is low, less than 11, it can within the abdomen, but not the liver. So TB peritonitis, malignancy. Whereas if it is high SAG, 11 grams per liter, it is most likely portal hypertension or cirrhosis. There another? That's it. So let's say you do the SAG and then from this only you move on. You do the SAG and you see it is low. Then you do the TB investigations. You can do the tumor markers. You can do the amylase. You can do the UFR. If SAG is high, you can do the ultrasound scan. You can do the full blood count. You can do the liver function test. You can do the liver biochemistry. You can do the serum electrolytes. You can do the alpha fetoprotein. Alpha fetoprotein, I forgot to tell you, if it is high, it indicates hepatocellular carcinoma. I'm sorry, I forgot. That is SAG. Any question for SAG? That's it. Another small thing, you all would have heard earlier we used to say transudate, exudate, those stuff. So you have transudate, exudate. So in one of this protein is low, in one of this protein is high. So in which is protein high? How do you all remember it? So one way I remember it is, please don't cancel me. Trans people have low protein in their body. So that's how I remember it. Trans people have low protein in their body. So transudate is low and they are all failures. So that means renal failure, hepatic failure, cardiac failure. Trans people have low proteins and they are failures. I don't believe that, but it's just one way to remember the stuff. Then exudate is opposite. So high protein and non-failures. So malignancy, TB, blah, 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 blah. Okay. That's all. Shall I move on to hematemesis? Okay. This is the last part. Okay, so in a SCQ, if they say give you an emergency and it's a 50 mark or 40 mark question, then you know ammata seri godak liyanna one. So there is a way you can approach it. For any emergency, which is a big mark question, there are 3 parts. This is what I follow personally. One is obviously the acute management. Then you have the intermediate management. Then you have the follow-up management. Okay, acute management, intermediate management, follow-up management. No, don't get overwhelmed. It's very simple. So I'll start with acute. For hematemesis, this is both for surgery and medicine. So if you all have to do surgery also, it's pretty useful. So acute person comes vomiting blood. You put him to HDU or close to acute side if you don't have HDU. A, B, C. For A, turn to left lateral. Why? To avoid aspiration. Breathing, nothing much. C is the most important thing. You attach to cardiac monitor. I'm sorry. After HDU and all, the patient is alive, no man. So you have to talk and reassure patient. And take a brief history. Mainly if they drank alcohol and if they have liver problems. And if on any drugs, especially warfarin. Okay. In any emergency, if patient is online alive, conscious, you have to first talk to the patient. You can එකපාරට මේ වම් පැත්තේ හැරුවත් patient gets scared no, talk and say බය වෙන්න එපා අපි from you, and then you take a brief history. You take the, whether he drank alcohol recently, if he has a liver problem, and if he is on warfarin, because these 3 are the main culprits for the hematemesis. So ABC, turn left lateral, cardiac monitor, and you check BP. If it is less than 90/60, it means he is going into shock. So cardiac monitor and pulse, blah, blah. So he's going into shock. Then the usual hemorrhage hemorrhage protocol we do, up to 2 liters, we can give normal saline. And meanwhile, get blood for investigations. Okay. The target hemoglobin is 9. 8, they say 8 to 9, more than 7 basically. So what are the investigations we do? We need full blood count. PT-INR, grouping and DT. 6 units, at least 6 units, because we don't know how much he is bleeding and how long he will bleed for. Okay. And then if serum electrolytes, because he's losing fluid, serum creatinine for drug purposes, and liver function test. Okay. Now to do all this, what do we need? We need IV access. So 2 large bore IV cannulas. Because when we are taking blood from the other side, we can give fluids and stuff. Okay. Yeah, that's about it. And then we start on the drugs. So the drug we start on, the drug we start on the patient is, the best drug we start the patient is IV terlipressin. Now, regarding doses, I have got different doses from different places. So what we learned from this IFM Japura is 2 milligram stat followed by 1 milligram 4 hourly till 24 hours. Now, these doses are quite hard to remember. So what I suggest is go to the ward and ask the intern IR, or if you're good with the consultant, the doses which we use in UHKDU. Okay. So due to that, I will not tell the doses, I will tell the drugs. Okay. So IV terlipressin or IV octreotide, if it is not available. In Kalavoy Hospital, they use IV octreotide. You also start the patient on IV omeprazole. Okay, this is because they may be having peptic ulcer bleeding. We do not know. So to reduce the peptic acid production, we give omeprazole. And then we give IV ceftriaxone because studies proven mortality benefit. Studies have shown that there is a mortality benefit. Okay. So IV terlipressin, the main drug is IV terlipressin or octreotide. Then you can start the patient on IV omeprazole. You should give them IV ceftriaxone. And yeah, studies have proven IV ceftriaxone is good. There is also a place for IV tranexamic acid. Okay. Then what we should do is, we are still in acute management. With acute only the bulk. After that, it's very simple. Keep him nil by mouth till you can do what do you call that? Upper GI endoscopy. Okay. Now we have to do the endoscopy. We have to see what is the problem, where is the problem. So for that, you have to inform theater or endoscopy room, inform surgeon, and that's it. Usually the usual upper GI endoscopy stuff. So in endoscopy, they can do banding or sclerotherapy. Banding is better. Then that depends actually on the cause. Like if it's esophageal varices only, banding or sclerotherapy. If esophageal varices. This is what's important in cirrhosis, no? However, if fundal varices, we do this thing. We cannot do banding because of its unusual place. It's on the fundus of the stomach. Ne? Banding karanna bad. So we do gel, cryoacrylate gel. Okay, cryoacrylate gel. I won't discuss peptic ulcers because that comes under surgery. Yeah, so we don't need that. Then yeah, that's about it. That is the acute management. Then you, after this, you bring the patient back to the ward. That is the intermediate management. Intermediate management can still inside the ward, but after you actively manage the patient. So here you have to see his other stuff. You have to decide on chlordiazepoxide. If he is dependent, alcohol withdrawal, sorry. These all depending on the scenario. Just remember it. And now he has bled now. So that means in his stomach there is blood. So this blood can be digested and it can produce protein. This protein can be absorbed and lead to ammonia. This ammonia can be hepatic encephalopathy. So we have to stop this whole nonsense. So you have to prophylactically treat for encephalopathy. Lactulose, rifaximin, same jargon. Metronidazole. Okay. Now, long-term treatment, follow-up treatment. You have to put him on a drug that uh, reduces the portal hypertension. So you start him on propranolol, long-term. You repeat the upper GI endoscopy in 6 weeks to assess the varices. If problem, rebanding. Okay. And then you do the clcd management, if any. This is it. And another important thing which we was told is, if patient already on propranolol and starts hemorrhage, stop propranolol because it drops BP. So in hemorrhage, anyway you lose BP, drop BP ne. ඒකට වැඩියෙන් තව propranolol දුන්නොත් BP will drop even more. So if they're already on propranolol in the acute stage, you have to stop the propranolol. Okay, any questions? Was it confusing? I felt I didn't do this part properly. Okay, we have like 10 minutes left. If you all have any questions, you can ask me. Any topic, not only CLCD, anything except renal. I hate renal. Any questions, any topic? Yeah, FFP and vitamin K, yeah. That depends on the PT-INR. So if the PT-INR is, what do you call that, high, you can, here you can give FFPN or vitamin K. So that depends, like if you want immediate improvement of PT-INR, FFP is better because it improves the PT-INR within 24 hours. However, if the PT-INR needs to be improved over time, then vitamin K. Yeah, packed red cells, that's why I said you need 6 units of what do you call this? DT. Target HB is 8 to 9. If the BP isn't going up, you have to give packed red cells. The normal hemorrhage protocol we learned in surgery. Yeah, tips is there in the management. However, it is like if varices doesn't heal, if sense taken Blakemore tube doesn't work, then you go for tips. So tips is, for anyone who doesn't know, transjugular intrahepatic portosystemic shunt. It's some kind of operation I've never seen. And if that doesn't work, you can go for open shunting. If that doesn't work, ultimate thing is esophageal devascularization. It's like a sequence. Yeah, follow up again. Yeah. So follow up is you have to give the patient propranolol because it has a mortality benefit. It prevents rebleeding. So it prevents rebleeding, and you have to repeat the upper GI endoscopy in 6 weeks to see whether the varices have properly, the banding has worked. If it's bulging out, you have to do rebanding of it again, and again in 6 weeks you have to check. Any other question? If you all, it's no oskine avulana no. Anything else? Nothing comes to my mind. Remember that history format. Get a good history, and I think you're good to go, because I know all of you all know the management. It's just that history is a bit difficult sometimes, especially depending on the patient we get. It's very luck based. It's not fair even, because some people get hard cases, some get easy cases. So it all depends. There's a component of luck. Don't worry though. This is a very important topic, but it's not that hard. So it's just memorizing a bit. It's right. Apart from that, you're set, good to go. Okay, then shall we call it? If any questions, you all can WhatsApp me or even